So, welcome to another 1HP Journal Club. This time we had a look at an article that had to do with how we kind of address fear and pain when just avoidance behavior is no longer working. So we're looking specifically at both cognitive and physical domains here, which is definitely within the PT wheelhouse and definitely relevant for a lot of our gaming population who frequently deal with pain by just pretending it isn't there or proceeding and accepting that pain is part of things. So that's not the optimal solution. So looking at this research a little bit more into changes in pain-related fear and pain when avoidance behavior is no longer effective. Elliot is leading the way on this discussion, but there's going to be a whole bunch of talking back and forth because this was a pretty like complex and nuanced study, wasn't it?
Yeah, I would definitely say so. So, I mean, you hit a lot of the major points there. I think we should talk a little bit more about what constitutes avoidance behavior in the real world, but we can save that for the discussion section. But yeah, so the author on this paper was Christine Villet, and the title of the article is Changes in Pain-Related Fear and Pain When Avoidance Behavior is No Longer Effective. Okay, so to dive right into this, we're going to start with what the purpose of this paper was. And kind of like the title said, the purpose of this paper was to investigate the effects of ineffective avoidance of a painful stimuli on subsequent pain-related fear and pain. So not just pain, but also the fear associated with the pain. They wanted to look how avoidance influences that. And also whether avoidance behavior persists despite its ineffectiveness. And a lot of times we do see that avoidance does become ineffective in managing pain, and it kind of is counterintuitive a little bit. But we will dive a little bit more into how they came up with their conclusions on that topic here. So they had three hypotheses to start out with. Pain-related fear increases when previously effective avoidance behavior becomes ineffective. The second hypothesis was experimental group participants who have acquired effective avoidance behavior during the acquisition phase will emit more avoidance behavior during the ineffective avoidance phase compared to the yoke control group. And third, they wanted to investigate the relationship between avoidance and pain measures. So they wanted to really dive into whether pain threshold and tolerance decline when the previously acquired avoidance becomes ineffective. So before we go too much further, I'd like to kind of give a quick and dirty kind of explanation of how this study was run. So they took a bunch of participants and they paired them together. And then the participants in the first group were linked with each individual participant in the first group was linked with an individual participant in the second group. And they both got the same results of their actions, regardless of what the stipulations were to receive the results of those actions. So the first group was the one that actually made the decisions, and they were able to learn by pressing a lever to select 3 different points that a robotic arm would reach to. And the different points corresponded to how hard they actually pressed on this lever. So the harder they pressed on the lever, the farther it went, and they reached a point. And there was different rules about each point on the lever during the first trial that they did. So during the first trial, if they pushed really hard and got all the way to that third point, they received a shock 0% of the time. If they went midway to the middle lever, they received a shock 50% of the time. And then if they went to the easiest point on the schematic there, they received a shock 100% of the time. So it kind of incentivized them to push harder to avoid pain. But then the second group, they received the same shocks regardless of what area of the regardless of which target they picked. So it kind of taught the second group that there really is no way to avoid pain, and it's just going to come at random no matter what. So they looked at a couple different things, which we'll get into a little bit more here, but just that's kind of the general gist of how this study was run. So you have a little bit more context as we move forward.
Let me just do like a quick little like kind of layperson translation on that hypothesis too, because it's a lot of technical terminology in the sense of pain-related and inhibition and avoidance behavior, et cetera, et cetera. So basically, they were looking at, does your fear of pain, they expected that fear of pain would get worse when avoiding it used to work and doesn't work anymore. As opposed to, they think that fear of pain wouldn't be as bad when avoidance didn't work in the first place and it still doesn't work. They also thought that if avoidance used to work, people are more likely to keep trying avoidance for a longer period of time than people who've already found that avoidance doesn't work. Like that group that you were talking about where basically no matter how hard they pushed, they were getting zapped, versus the group that, depending on how hard they pushed, they might or may not get zapped. Carry on.
Also, zapping people is pretty metal. Like, can we just talk about really how metal this study was? They literally electrocuted people if they chose poorly.
You have chosen poorly.
Zap.
All right. So, kind of, how did this study design work? Because you got to use the term operant conditioning when you were describing this, and I got real excited.
Yeah. So this is more of a psychological study than it is really a musculoskeletal physical therapy type study. So the type of study that they actually performed was a randomized yoked control procedure. And that is a research design used in operant conditioning experiments, which it comes from the world of psychology. And that is actually a method of learning that occurs through rewards and punishments for behavior. And I would call getting zapped a punishment. I don't know if you can call not getting zapped a reward. In that case, I'm getting rewarded all the time.
There's actually a specific term for that. I remember this from my Psych 101 classes. So there's different types of feedback that you can get, and there's different types of reinforcement you can get, and so there's a difference between a punishment, which is the application of a noxious stimuli in this case, or a negative reward, or I'm going to use the wrong term here, but basically the removal of a painful stimulus is also considered a positive feedback mechanism.
Yes.
All right, sorry, carry on. I got to geek out about my psych stuff for a moment.
This nerd break brought to you by Caitlin McGee. All right. Anyhow, so they matched.
This whole thing is a nerd break.
Oh yeah. Well, the nerd break from the nerd break. Anyhow, so the matched research subjects were yoked together. So that's where the yoke part comes together. So they were joined together. So subject A got joined with subject 1 from the other group. So you had the experimental and the control group, and they were linked together in a 1-to-1 ratio. Kind of like that. So operant conditioning is said to have occurred when frequency of a class of behavior is changed by its consequences. So basically, if you can change a behavior based on the consequences, you've performed operant conditioning successfully. And it's through either, like we said, punishment or reward. So reinforcement occurs when the rate of behavior increases. Punishment occurs when the rate of behavior decreases. So that's kind of how.
This with like our pets. So, for example, if you have a cat and your cat tries to eat your plants, and you spritz your cat in the face, that's a punishment. The cat can be said to have been operantly conditioned when it stops eating your goddamn plants.
Excellent example.
This has never happened in my real life or anything like that.
Unless it's catnip, in which case.
Then it can eat all of the plant at once, or cat grass. Also, basil. Cats can eat basil. It's fine for them.
We are now shifting over to a
really important now.
Research
this is now veterinary.
Just kidding. Okay, go on.
All right. So next, let's talk about the inclusion criteria and exclusion criteria here. So to be included in the study, you had to be healthy, pain-free, and you volunteered to be in it because it would be very unethical if we were shocking people against their will. And also to note that at any time, the participants could say they wanted to terminate their participation, or they could ask to have the intensities recalibrated to be lower than what previously was chosen at the beginning of the session. So exclusion criteria, anybody with a chronic pain condition, pain of the dominant forearm, uncorrected vision, cardiovascular disease, medical advice to avoid stressful situations, psychiatric disorders current or in the past, neurological conditions, or were pregnant. So
those are all good exclusion criteria.
Yeah, I think you'd want to avoid.
I like not accidentally zapping babies.
Yeah, can probably probably get into a lot of trouble for doing that.
It is also important to note that something like the exclusion of folks who've had mental health conditions in the past or in the present, we do know from research that there's a pretty significant link between things like depression and low back pain. So I definitely see why they removed that as a confounding variable as well.
Right, and you don't want to trigger some kind of PTSD episode with...
Also don't want to trigger somebody, correct.
Yeah. So next, let's talk about how the subjects were chosen. So they were recruited at KU Leuven, which I believe is in Germany, maybe? I'm not sure. And they used social media and the distribution of flyers around the campus. Psychology students actually received a course credit for participation, and other participants received a monetary compensation of €6, which does not seem like a lot to get zapped, but you know, if you're a struggling college student, you'll do pretty much.
Any money helps when you're a broke college student. We've all been
are these people representative of the population? They were a pain-free population, so I would not say that they are necessarily representative of people that have chronic pain, but it definitely can be interesting to look at how these things work on a smaller scale. Any thoughts on that one?
This is also the kind of thing, well, I think it's really good to assess this in a pain-free population in the first place, in part because somebody who already has pain may have already implemented some of these strategies that they are trying to research. And so it would be really hard to say whether this was a behavior that they were operantly conditioned into in this specific study, or if this was an adaptation that they'd already developed to deal with the pain that they were having at baseline.
Right.
So
I agree with the way they did this.
It might not necessarily be relevant relevant to a chronic pain population, but I think we can reasonably hypothesize about folks with acute or kind of acute on chronic pain, even if we can't necessarily make assumptions about folks with chronic pain based on this. Indeed.
So next, we want to talk about biases and if there's anything done to limit that. And as far as I know, that the study randomly allocated people into groups, but they didn't really discuss any blinding going on. I may have missed it, but I'm assuming that the yoke group did not know that they wouldn't be able to learn a pattern, or that the other group was able to learn a pattern. I don't believe that the two groups knew what the others were doing. But again, I did not see that expressly stated in the study, to the best of my knowledge.
That seems plausible, but as we all know, when it comes to medicine and science, if you didn't write it down, it didn't count.
Yeah, exactly. So let's talk more about how the control group was chosen. So they used random block allocation, and with a randomized block design, the experimenter divides subjects into subgroups called blocks, and the subjects within each block are randomly assigned to treatment conditions. And this is different from a completely randomized design because this design helps to reduce the variability within treatment conditions and potential confounding factors, and produces a better estimate of treatment effects. Because when you were running a study with the yoked design, you want to have this kind of block thing where you can control more within groups. So I like what they did there. Let's talk next about how they followed up and the outcome measures that they used. So first, they used verbal ratings of pain, pain-related fear, pain expectancy, and avoidance. So after each block of the 24 movements, participants reported their answers on a numerical rating scale from 0 to 10 for pain-related fear, pain expectancy, pain intensity of the trajectory, and fear of actually having the pain, and also how much they wanted to avoid the pain. So there's some.
How much you want to avoid the pain would be fairly high every single time, but maybe that's just me.
Right. I can imagine that would be the case as well, but
that's likely a consistent answer.
That is what we are looking at here. So they looked at behavioral avoidance, maximal deviation, and movement choice. So the avoidance behavior was measured through the maximal deviation from the shortest trajectory, So that's how far they were willing to go, or the farthest distance that they were willing to go to avoid the pain. So that's kind of how they measured avoidance. And threshold was measured during the recalibration phases. So after each, or at the beginning of the study, they had them rate the electrical stimulus that they were receiving on a scale of 0 to 10, 0 being no pain at all, and 10 the worst imaginable pain. And then they recorded that in milliamps from the 3 to the 8 rating. So they kind of had like a little window as to what was tolerable pain for the person during the trial. And I believe they were using 8 out of 10 pain for the stimuli, the electrical stimuli. So that's some pretty significant pain.
That hurts.
Yeah, that's not fun. But the way that the threshold or the amount of stimuli necessary to make you feel a certain sensation of pain was measured was done through the actual milliamps of the electrical stimulation. And then those were recalibrated after the initial acquisition phase, and then recalibrated again after the ineffective avoidance phase. They asked them the same questions: how high would you rate this pain at this this amperage? And then they kind of saw how the threshold, the ability of the patients to tolerate pain, changed as they went on through this study.
I really like that you corrected yourself to amperage instead of voltage. I'm proud of you.
Thank you. Well, it's milliamperage actually, but that was too many syllables. Yeah. So fear, expectancy, intensity, and avoidance all were measured in some way, shape, or form. Right. Anything else?
Did anybody drop out?
No, none dropped out, which is surprising to me.
I guess maybe there was a bunch of masochists in there. I don't know. Or
Maybe.
People who are really dedicated to the science. Probably the latter. Also getting paid. Like that's, I mean, like €6. That's like pizza money. That's a pizza. That's dinner.
That makes a big difference when you're trying to recruit subjects for research, is if you're paying them or not. That does actually make a huge difference.
And I will say that is actually one of the things that is important to consider when it comes to bias. Are the people who volunteer for a study kind of unduly influenced to participate if they're given something like a credit towards a class or pizza money?
Right.
And that's why there's a whole bunch of review processes that any study has to go through before it can be conducted, especially one that's conducted on human subjects. And one of the things that they look at is like, are we providing an unfair amount of influence to try and get people to do a thing? And are we potentially incentivizing people to lie in order to meet inclusion criteria to try a study like this? Which I gotta say, pizza money probably not enough to make people lie about not having certain conditions.
Right. So there definitely is a fine art associated there.
There is. So how did they analyze the data that they discovered?
So they used a repeated measures ANOVA for pretty much all of their calculations, and repeated measures ANOVAs are useful when you are looking at 3 or more time points or mean scores, or 3 or more something or other that you're trying to measure. So either you're looking at changes or differences, and you might do something like this if you were interested in investigating the effect of a 6-month exercise training program on blood pressure, and you want to measure blood pressure at 3 separate time points. So like before, midway, and then after the intervention. So this kind of fits for ours because there was essentially 3 data recording sessions for all of the subjective and objective outcome measures that this study had. So it works well in this area.
All right, and you're right. This is absolutely the appropriate method. It's a repeated measures. We are measuring kind of the same factors over multiple points, looking at things kind of ahead of time, during, and after. And then there were a number of phases to go through. Right, they did the practice phase to get used to how the movement worked. They did the acquisition phase to see, like, learning the pattern if they were in the learning pattern group, or learning that there isn't a pattern if they were in the not a pattern group. Then the recalibration, then the phase where avoidance no longer works, even if that was what you'd originally learned, and then recalibrated again.
Yes.
So what did we find out?
The results. All right.
Ba-ba-ba.
So The results indicate that participants become more afraid of and sensitive to pain when previously acquired avoidance is no longer effective. Also, participants continue to show avoidance behavior despite it being not adaptive anymore. And these findings suggest that ineffective avoidance may play a role in the maintenance and development of chronic pain. So, some really interesting conclusions that we saw here. So let's break down their hypotheses one by one. So the first hypothesis was that pain-related fear increases when previously effective avoidance behavior becomes ineffective. And the results showed that pain-related fear for different trajectories evolved differently from the experimental group from the yoked control group over time. So they actually were more scared to go farther and exert more effort to avoid. Or hold on, let me make sure I delivered that properly.
Okay.
The fear, so the trajectories were associated with different pain levels, right? So the more that they were unable to accurately get a reliable result due to the pain levels, because they changed from the first acquisition phase to the ineffective avoidance phase, they actually saw more pain-related fear associated with that as their method of avoidance became more unstable. The crucial comparison in the experimental group was seen in the expected increase of pain-related fear from the acquisition phase at 50% reinforcement to the ineffective avoidance phase, which was also at 50% reinforcement. So nothing changed there, but they actually saw more fear from one phase to the next just because the other phases in that cohort were less reliable as far as avoidance goes. So there was a significant increase in pain-related fear for the experimental group from 0% reinforcement to 50% reinforcement. And that makes sense because if things are getting more painful, despite you doing the same thing that you were doing before, that's obviously going to increase more fear. But overall, it is interesting to see how fear is increased as your method of avoidance becomes less stable. And I think we see that a lot. We'll talk about that more later.
We can. I'm totally fine with given how many different conclusions you do here. I'm fine with doing a conclusion and then a discussion of that conclusion.
Yeah, let's talk about it now.
That works in this particular phase. So this first one was really interesting. It was exactly what they expected. That when initially you've got something that works to manage your pain, and then all of a sudden it doesn't work, or to avoid the pain, and all of a sudden it doesn't work anymore, you are more afraid of when the pain is going to happen because it's unexpected and unpredictable. That absolutely makes sense given the general human psyche, right? Like we spend a lot of time worrying about things that may or may not happen, especially folks with anxiety. And the fear of those things is sometimes worse than the thing itself. And even more so, it's when all of a sudden what had been working and what had made sense no longer works and no longer makes sense, it dispels the accurate or not illusion of control that you had over a situation. Our ability to have control over a situation is really key in our ability to that sense of an internal locus of control, a sense of ability to affect a situation. When it's no longer within your control, not only is it going to hurt, you don't know when, you have no way to brace for it. You are far more afraid of the unknown than you are of just the pain. So of course your sense of fear about that situation is going to be higher. But I was really interested in this particular result.
Yeah, and it makes so much sense, and kind of ties in with the second hypothesis that they presented here. So the second hypothesis said that experimental group participants who have acquired effective avoidance will emit more avoidance behavior during the ineffective avoidance phase compared to the yoke control group. So as they started to lose control of their ability to control their pain through the strategies that they had developed, they tried harder and harder and harder to avoid the strategies. They were always choosing that farthest distance that they would have to go to try to avoid their pain, but it wasn't working, which was driving them into kind of more of a frantic situation. So I think that it's kind of a vicious cycle that feeds on itself. And I really think taking a step back from your pain and trying to understand the why, or trying to understand how to break that cycle, is really important from developing these chronic pains that we see.
Yeah, absolutely. It's when something is working, of course we want to stick with it, especially when it comes to pain. But when it no longer works and we can't necessarily see a clear reason as to why it no longer works, it's, I guess our instinct is, this was working, why is it working? Maybe I'm not doing it well enough, I got to keep doing the thing. But if the avoidance eventually stops working, I think especially with chronic pain, and when we're talking about chronic pain here, we're not talking about chronic pain conditions like, say, Ehlers-Danlos syndrome or fibromyalgia. That's a very different thing. We're talking about when an acute or subacute injury becomes a chronic injury because it goes unaddressed, to be clear. That when that avoidance strategy is no longer effective, it's often to the point where recovery takes a far longer time. And in fact, there may be some increase in pain temporarily while the recovery begins, which of course, when your pain-related fear has become higher, and then as part of your treatment and recovery, your pain's going to get even higher than that, of course that's a barrier to recovery. Of course that's a reason that you would want to continue with an avoidance strategy and would be less likely to be invested in something like physical therapy. We see that a lot with our patients who have chronic tendinopathies, that a lot of the times, if this is something that had been intervened on early, really wouldn't have been too much of a problem. But because it was low level enough that, well, I could just, only play for half an hour at a time, or I could just, play for a while and then take a break in ice and it's good enough, rather than addressing the underlying cause. By the time they get to the point where there are no avoidance strategies that work anymore, all of the things that address underlying causes, one, are a bit irritating to the tissue, and two, take a lot of time to work. So that was for me a really key interpretation of this particular result, that we can look at the process by which an acute injury can become chronic due to avoidance strategies, and why it might be that an avoidance strategy continues even when it's no longer effective, because at one time it was.
Right. I think there's another perspective we can look at too. If we just take a step back and look at the actual methods of the study, right? They're only allowed to stay within the confines of pressing a certain distance to achieve a certain result, and when it doesn't work anymore, they're only limited to that, to pressing a certain distance, right? There's no other option for them. And
they have no variability.
Yeah, exactly. But if we zoom out and take a case like tendinopathy, lower back pain, in their eyes, they are only perceiving that that's the only option, right? Because they're not aware of some solutions that physical therapy education, or even just general education from better pieces of authority online, can provide to them. So it's really super, I guess it's such a great description, or great parallel to how a lot of us deal and experience with chronic pain in the real world, especially in the gaming community. So many of us don't know what the solution is or what we can do differently, so we only go with the same route. We see what everyone else does, which is continue to stop, continue to rest, continue to use a brace, all these things that, yes, might have worked before, but the conditions of the actual injury might have changed. So we have to be educated, or reach out, or find someone that will help provide us with the right solution to, like Kay said, address what the underlying cause and really prevent it from getting to.
That's a really good perspective that I hadn't considered, especially the link between the limited responses available to the people in this study and the perception that there are only limited responses available to us in the real world. In reality, there are tons of responses available. It does also tie to, a lot of people when they have back pain think chiropractor, because that's the immediate association their brain makes. When in reality, a more effective approach might involve physical therapy and some degree of cognitive behavioral therapy as well, because we know there's a huge link between depression, anxiety, and low back pain. But those are things that we know as medical professionals. This is not necessarily information that our patients know. So it's really, this is a really key reminder to us as medical professionals of the importance of outreach and the importance of education. And I'm not saying that, all consumers are absolute idiots who know nothing, and we the benefactors from on high should be telling them what to do. It's more just, there is so much misconception out there. There is a lack of information out there. We can absolutely do better at letting people know that, hey, you do have options, and here's kind of how those different options work. And I think it's really important for us, particularly in the gaming community, because we're in this really great position where we're starting to be seen as people who know what the fuck they're talking about, because, hey, heads up, we actually do know what they're talking about. And so having that degree of buy-in from the community, having people who recognize, like, these are people that I can ask these questions of and not feel stupid, more importantly, I think that's really, really key for changing the, I guess, accessibility of information. And I think this is a really crucial reminder to us as medical professionals of the importance, not just of treating the patients who are on our caseload, but of reaching out to the folks who might someday be patients and making that data accessible for them so that they can make the best decisions for themselves.
Right. And it's a fine line that we walk as medical professionals where obviously there's a certain amount of marketing that has to go into selling what you do, but also not taking that as an excuse to sell yourself as a cure-all for everything.
Right.
Really understand the importance and communicate the importance of interdiscipline collaboration between you and other healthcare professionals. Let people understand that it's not, there is no one size fits all. There is no easy solution to pretty much any problem in life. There's some kind of complexity and nuance to it, but that's not necessarily what people are coming to you for. They want the kind of easy solution. So you need to find ways to integrate that information in ways that they can process and understand, and also give them the options in a clearly presented manner.
I think this also ties into one of the really important things that we can do as medical professionals, and I'm not just speaking here about physical therapists, but any medical professional, is that when we give our patients a sense of control over what's happening to them, they have less fear about what's happening. We see this in the research here, and I think we can generalize that information. When our patients feel as though what they are doing to recover is within their locus of control, that's absolutely a huge boost in their, I guess, their confidence, their interest, their degree of investment. It's why I've done things like, when I've had patients with low back pain and have scored higher on some of our depression screening questions, I have a bunch of trusted mental health therapists that I've referred people to that have really made a difference for my patients. When it comes to things like explaining why we're doing a certain exercise, so the patient isn't just doing a thing because I told them to do a thing, but because they understand the why. Yeah, not everybody wants to sit there and hear a whole explanation of the various order in which things are firing and need to fire, but the more people understand what their body is doing, the less of a mystery it is, the more sense of control you have over what it's doing at any given time, and that absolutely decreases fear, as we see here in this study.
Right. And that's why I think education is one of the number one important things that we do. As much as we like to value what we do with our hands or what exercises we prescribe, I think really taking the time to bust out the models in front of your patient and show them exactly the structures that are possibly involved in their pain and exactly what their options are in dealing with it, I think is so important for us as providers.
Absolutely. And I certainly hope that our patients feel the same way, that, the kind of medical professional that they want is one who gives them not only time and not only hands-on work, but also that sense of control and a degree of understanding. I know, Matt, this is a thing that you do as well. When you get done with an evaluation, you ask your patient to kind of explain back to you, like, okay, so what do you understand about, what's going on for you? And part of that is, figuring out, did I communicate effectively? But part of it is, does my patient, have a grasp of what's going on for them? And do they feel as though, do they feel confident in their understanding of it?
Yeah, absolutely. And a big part of that too is just teaching them how to approach their own health and having them take responsibility for what is the most important thing, their body, and how they approach being healthy. I think that's so undervalued in the community right now, and that doctors just and even some physical therapists just assume that, hey, everyone really cares about their health and they have this perfect approach and they want to seek what's best. But in reality, there's people that are just lazy. They just want to seek out the authority and just have them tell them exactly what they need to do. But to a certain extent, because it's your body, you need to actually listen. You need to take care. You need to really understand what we're telling you and why, so that everything that you're doing to make whatever you're dealing with better makes sense, right? And there's some context to it. And then again, that gives you that control that you've been speaking about. And overall, that will help with the speed or time of recovery. So
absolutely. I think that's a really key thing to make clear, especially to our patients who are like less interested on kind of the face of things of learning about like the whys and hows behind their condition. I think no matter what, people want to get better as fast as they can. So if we can help people understand that, hey, the more you grok about this, the more that this makes sense to you, the faster you're going to get better. That's something that more people can buy into than just, I'm going to know everything about my condition now. If you give them a reason to give a shit, which is I'll get better faster, that's absolutely tying into what's in your patient's best interest and not just what you wish your patient thought.
Yep, exactly.
Nailed it.
So where were we? We got to hypothesis 2 or something.
That was hypothesis 2.
That's
there
right.
is a third hypothesis, more of an analysis. They looked at pain threshold and pain tolerance, which kind of seem like the same thing until you get into them a little bit further, and they're different, trust me. But as we talk about giving people more options for empowerment and knowledge, I just tell you to trust me.
I wasn't going to say it.
Nice.
Anyhow, the data suggests that the pain thresholds for the two groups evolved differently over time, and that the experimental group actually had a lower pain threshold and tolerance than the yoked group that really didn't have any opportunity to learn an avoidance pattern. So basically the take-home point away from this is that pain that you thought you had control over and then lose control over is worse than pain that you just have no control over and is just chaotic and random. Which I think is a really important lesson to take from this, that if we can give people, again, more control over their pain and give them lasting strategies, it's better than giving them something and then taking that away. Like, I think modalities are a great example of this. Modalities will work for a while. They will mask the pain, but you're effectively doing nothing to actually alleviate the source of the pain. So I really think as clinicians, it's on us to get in there, determine what the tissue source of the pain is, and then try to treat that as best we can instead of just being therapists that use Band-Aids on things.
Right. And there is the important consideration of if you throw everything in the kitchen sink at your patient, you're going to have two problems. Problem number one, you're not going to know which one actually worked. And problem number two, if you're throwing everything because you're not entirely sure what's going on, your patient is going to recognize that and they will perceive less control over the situation as a result. And that's going to set you back even further. So I think it's also really important for us as clinicians to be able to draw on our colleagues and to recognize when our answer is, I don't entirely know. I still do things like this. When I have, when I have a really unexpected result on a certain test, like the time that I was doing a test to determine if somebody's transverse ligament was intact or not, and I got a positive result that it was not intact. I had another clinician do a second test because one, it was really unlikely and I was very concerned. And two, I really wanted to be sure for my patient. Mm-hmm. And I think when we are honest with our patients about what we know, and when we acknowledge that there's a thing that we don't know, here's the person I'm going to, here's how I am solving this and finding it out for you, I think it gives them a lot more reassurance in us as professionals to be able to trust that when we tell them, I know what's going on, we know what's going on.
100%.
We do a lot of soapboxing in this particular episode. Sorry, guys.
Hey, soapboxing is great.
All right, so moving on to kind of the discussion section, although we have done a lot of discussing already as well. Are the conclusions drawn in this study justified based on the data available? Yes or no?
I would say yes.
I would say absolutely yes as well.
Yes.
Sweet. 3 out of 3 physical therapists say yes. Are these results generalizable to a larger population, and why or why not?
So I talked a little bit earlier about how chronic pain patients develop their pain over time, and these patients were involved in one session here. So I would be careful about generalizing these to chronic pain patients just because the time component isn't there. But I definitely do think that it gives us a nice small snapshot of what these processes can look like over time in a very small window.
I agree. I think this is a thing that I think similar to the way that we're able to use computer modeling to predict what climate change might look like, even if we are not 100% sure about how things are going to shake out. I think in the same way we can say this study did not directly give us a corollary to chronic pain, but based on our understanding of how people process pain, fear, and their ability to impact their pain, I think it's reasonable to draw some conclusions about chronic pain that may allow us to provide better care to our chronic pain patient population.
Right. And I would say that the fear component is also minimized. I mean, if you're going to a lab with people in white coats that have a bunch of expensive equipment and are at a reputable university, you can kind of assume that they're not going to do anything to hurt you.
Probably.
But we've been wrong in the past about those sort of things. Hence why we have IRBs.
Yes.
And so that may have been limited a little bit there, but overall, I think that they really captured what they wanted to capture here.
I would agree with that assessment wholeheartedly.
Alrighty, so clinical and statistical significance of the results of the study. I think that everything was evaluated at a statistical significance for all of the statements made. Specific statements being patients with pain that may have come from an initial injury can increase the pain they experience and decrease their tolerance to less painful stimuli. The availability of avoidance through although ineffective, may have led participants to perceive danger starting a vicious cycle. And avoidance could increase threat perception, resulting in an increase in pain-related fear, which in turn increases avoidance behavior, even when it's ineffective. Also, the participants that did not have an opportunity to learn how to avoid their pain did not have the same decreases in pain threshold observed by the experimental group. And for the esport athlete that adopts a different strategy of movement or an assistive device like a brace, they may be worsening their condition instead of addressing the underlying impairments.
I think you're pretty good there with your clinical takeaways. And I think we also hit on a number of the takeaways, not only for patients, but also for us as professionals.
Yeah, that's just more or less a little recap of everything that we already discussed here.
Exactly.
Shortcomings of the study, some really complicated and nuanced stuff about their data analysis that the authors reported. To get into it here, but I think that that may be best left alone. Nothing too crazy. It's just that they the reinforcement for the yoked group actually went up instead of staying somewhere around the same percentage during the ineffective avoidance phase. So the yoke group actually got an increased dose of pain compared to the experimental group. So they ended up with some strange results for what was the value there? For pain-related fear. They got some strange results for the yoked control group that didn't really match up with the rest of the results that they were seeing. But that was one of their suggestions for future research, is that they kind of standardize that a little bit more so you don't see a dramatic jump just due to the RNG of the setup of the experiment. Alrighty.
All right, so what did they suggest for future research?
So for future experiments, the author said that they should control for that scenario that I just spoke about. They said also future studies might also consider framing the movement task as a game to try to maximize participant engagement. I don't know why they made that statement if they were having difficulty with participant engagement, but I would assume that shocking people might be more pleasant if it was in some kind of a game. I don't know. And they also recommended future studies to include physiological measures of pain-related fear, something like eye blinks, startle measurements, skin conductance, cardiac assessment, just to kind of get an idea of the pain-related fear is also physiological in nature.
Yes, and of course, us PTs being physical folks would love to see that kind of data as well.
Yep.
Right. Any kind of biometrics are really cool.
We get fed by biometrics all the time.
Yeah. So, what did I see as the shortcomings of this study, you might ask? So overall, I think the study was
ask that every single time we do Deer Club, actually.
Well, I'm glad you asked. Overall, I think the study was well designed. I personally would have liked to see it performed on a larger scale over a longer period of time to kind of address that chronic component. And not much was done as far as like musculoskeletal contractions go. They recorded that data when they were calibrating the robotic arm for pushing the lever to actually make it move. So they actually recorded like maximal contraction to kind of associate it with that. But not much was really done with that data to see how it changed over time based on the pain that these people were experiencing, because the electrodes were actually placed on the triceps, which was the main muscle responsible for moving that arm. So I really think that it would be interesting to kind of plot how that force contraction changed over time based on the other fear avoidance metrics that they were looking at. And for future reference or future research, I would definitely be interested to see some studies that use this design with like EMG and EEG data to kind of look at that muscular contractility as well as the corticospinal excitability. Because I know there's a lot of research coming out now that really is looking at how chronic pain is influencing actual excitability in the brain and actual contraction of the muscles, which lead to problems, especially with tendinopathy. So I would really like to see how kind of all of this interplays truly with like tendon neuroplastic training type of mindset. And I would also like to know what we can do about the data that we've been given. I think we talked a lot about things like that in our discussion. If ineffective strategies of reducing pain cause increased fear avoidance, what are useful strategies? And I think that we talked a lot about that. And I think exercise would be at the top of the list there. Exercise and strengthening, I think, should be incorporated into a future study from a PT perspective, just to see how those interventions really do change people's perception of the pain that they're experiencing, whether it be musculoskeletal or electrical in nature, and if it actually does have any impact on their amount of control that they feel in the situation where they are being placed under like harmful conditions, essentially.
I agree. I think that it'd be really good to see if we give some other form of control, even if that form of control isn't the ability to affect exactly when the pain is going to happen or knowledge of when the pain is going to happen. Do people perceive that that is significant enough control to offset the fear of the pain?
Yeah, overall good stuff. I definitely think there's a lot that could be done here, and pain science is such an evolving and interesting field with a lot of big names talking about it now. There's always so many ways that you can blend what we do as physical therapists and make almost any study in a lot of other fields applicable. Beautiful thing about physical therapy, but I really think that the pain science and physical therapy fields really do overlap a lot.
They really do.
And yeah, that's all that I have.
It was a lot, to be fair, but this was a really good study. I think it's really applicable for both the medical professionals who are in gaming or not, and for the gaming folks who deal with pain in some capacity. I think the single most important thing for medical professionals to take away is how absolutely key it is for us to give our patients a degree of control through education. And I think the big takeaway for patients is or for folks in general who aren't medical professionals, is knowing what your options are will help you so very much. So don't be afraid to seek out answers outside the box. Especially, exactly. If all you've been doing is avoiding the pain, there's probably something else we can do. If you don't want to know what that is, hit us up and find out.
And exactly. Even if you have pain that you feel is not a big deal right now, but yet it is persistent, please seek somebody out for it, because as the study shows, that pain that's small today can become much bigger tomorrow and the next day, even if there is no actual change in the tissue that is causing that pain in the first place. Even if the tissue is getting better, you can still snowball into kind of this chronic pain syndrome if you allow it to do so. So make sure you guys are seeking out not even just one option. Talk to multiple healthcare professionals, get their perspectives on what's going on. Educate yourself. Knowledge is power. So I'm going to leave you all with that.